We're going to discuss cardiac output in a number of different ways, and we're going to first go through it by discussing equations and some mathematics, and hopefully with these equations you can understand the concepts and it can be more clear in your mind. Remember, cardiac output is equal to heart rate times stroke volume. This equation tells us that the heart's total output, or the cardiac output, is a function of both the heart rate and the stroke volume. You remember what the stroke volume is? It is the volume of blood ejected during systole. Very good. So it's the exact amount, or the volume, of blood that goes to the rest of your body as your heart pumps, and specifically when your heart pumps. Do you remember how you calculate the stroke volume? Stroke volume is calculated by subtracting end systolic volume from the end diastolic volume. Very good. So stroke volume equals end diastolic volume minus end systolic volume. And if you multiply that by the heart rate, you get your cardiac output. So there could be a situation on the test where they provide you with these variables, end diastolic and end systolic volume, say in the context of an echocardiogram. And they give you the heart rate, and they want you to calculate your cardiac output. So hopefully you can remember this equation and then get this question right on test day. Another way to calculate cardiac output is by using the Fick principle. I will say that this is a largely theoretical exercise here and practically is not often used. The reason why is that the principle states that cardiac output is equal to the rate of O2 consumption over arterial O2 minus venous O2 content. So in reality, we can calculate and measure arterial and venous O2 content, but it's really difficult to measure the rate of oxygen consumption. So in theory, or in practice, this principle is not often used. But the point is, and the principle that comes out of this equation, is that oxygen is extracted from tissues at a rate proportional to the blood flow, or cardiac output. So we can see here that when there is a greater difference between arterial and venous oxygen, when the denominator is larger, the cardiac output is lower, which makes sense because as there is more time, if there's cardiac output or cardiac dysfunction, systolic dysfunction, there's more time for tissues and capillary beds to extract oxygen, and thus we see a greater difference between the arterial and venous oxygen content. Calculating the rate of O2 consumption requires us to analyze expired air, and it's somewhat difficult to do in clinical practice. So this is more of a conceptual exercise to sort of understand that cardiac output is related to oxygen consumption in tissues. The next equation for us to discuss has to do with the mean arterial pressure, which I will put in short as MAP. The mean arterial pressure is exactly what it sounds like. It is the mean or average blood pressure in the arteries during a single cardiac cycle. If we break down a cardiac cycle, we remember that it is composed of both a systolic and a diastolic phase. Which one of these phases takes longer in someone that's, say, beating at 60 beats per minute? So remember, the heart spends more time in diastole than systole. In fact, it's usually about 1/3 of the time in systole versus 2/3 of the time in diastole. So in order to calculate the mean arterial pressure, you need to account for these differences between systolic and diastolic phase and incorporate that into the equation. So the equation is mean arterial pressure equals 2/3 diastolic blood pressure plus 1/3 systolic. Very good. Mean arterial pressure can also be understood as a function of cardiac output and total peripheral resistance. So this is an important equation, which is MAP equals cardiac output times total peripheral resistance. You may remember this equation from your MCAT days when you were studying fluid flow in the physics section. It is a basic equation of fluid flow. Pressure equals flow, or I, times resistance. Where flow, we talk about here, is the cardiac output, and the resistance in the system is the total peripheral resistance. Now, do you remember which vessels in our vascular system are responsible for generating this concept, or this total peripheral resistance? Is it the veins, the arteries, the capillaries? The arterioles. Very good. The arterioles are the segment of the vasculature that predominantly produce the total peripheral resistance that creates our blood pressure, our mean arterial pressure. We'll go into that more. The arterioles are the parts of the vessels that precede the capillary networks and contribute most significantly to the total peripheral resistance in our bodies. So breaking down this equation even more, mean arterial pressure equals cardiac output times total peripheral resistance. We remember from just a few minutes ago that cardiac output is equal to stroke volume times heart rate. So we can fill in the variables here and say that mean arterial pressure is equal to stroke volume times heart rate times total peripheral resistance. And remember that stroke volume is end diastolic volume minus end systolic volume. So here, with all these variables that may be given to us on exam day, we can begin to look at calculating our mean arterial pressure. I cannot emphasize to you how important this equation is to understanding hemodynamics. I almost can guarantee you that this will show up on your exam, and particularly in your future clinical years, this will be an important concept to have down in your mind. This equation really should make sense if you think about it theoretically, that mean arterial pressure is equivalent or associated with cardiac output and total peripheral resistance. As your cardiac output increases, as the heart beats faster, and has more volume, you can imagine that your blood pressure goes up. Remember, we're talking pretty much about blood pressure, mean arterial pressure by multiplying diastolic by 2/3 and systolic by 1/3 and adding them together, so we're talking about blood pressure here. So as you increase cardiac output significantly, you increase mean arterial pressure, your blood pressure goes up, and if you increase your total peripheral resistance, if you make your arterioles constricted, for instance, you have an increased volume going against a smaller tube or a smaller hose, and that results in increased pressure, just like when you put your thumb over a garden hose. You increase your total peripheral resistance, you increase that resistance the heart's pumping against, and so you also see an increase in your mean arterial pressure. So this is something that I hope makes intuitive sense to you, and something that you can think about fairly quickly and easily when you're on the wards assessing hemodynamics of a patient in the ICU that's on a vasopressor such as norepinephrine. This is sort of an equation you're going to come back to when you're talking with your ICU attending and making decisions about what to do with your critically ill patient. So I cannot emphasize how important this concept is for your future medical careers. So next we're going to talk about pulse pressure. Talk about pulse pressure, shorthand 2Ps, and this is defined as the difference between systolic and diastolic blood pressure. So why does this matter? Well, is it important to know that pulse pressure can vary associated with certain pathologies or certain diseases. So by calculating this pulse pressure, we can sort of use it as a diagnostic tool to make a diagnosis in our patients just using the blood pressure. So to spend a moment to talk about the conditions that decrease our pulse pressure, we'll start with that. Can anyone think of any conditions that cause a decrease in our pulse pressure? So first, let's think about it. When I say decrease in pulse pressure, I mean either their systolic blood pressure is lower, their diastolic blood pressure is higher, or their systolic pressure is high, but their diastolic pressure is even greater. These are the situations where we would see a smaller pulse pressure. So aortic stenosis is a common cause of decreased pulse pressure. And we see this because we see the stenotic aortic valve decreases the amount of ejected blood, so our systolic pressure essentially goes down, while our diastolic pressure stays about the same, so we see a decreased pulse pressure. We can also see this decreased pulse pressure in cardiogenic shock, as well as heart failure. Because in these situations, we see a decrease in stroke volume, we see a decrease in cardiac output, thus we see a decrease in our systolic blood pressure, and a resultant decrease in our pulse pressure. Very good. Situations that increase pulse pressure, or diseases that increase our pulse pressure, include situations when there's an increase in our stroke volume, or we see a decrease in our arterial compliance. Diseases include hyperthyroidism, as well as an increased adrenergic state in general. Increased adrenaline or adrenergic signals results in an increase in pulse pressure, or a greater difference between systolic and diastolic blood pressure. We'll also see it in obstructive sleep apnea, and the physiology behind this is quite interesting because in obstructive sleep apnea we see an increase in sympathetic tone, and this is because we see an obstructed airway which causes a decrease in oxygenation of the blood, and our chemoreceptors in the medulla, in the brainstem, turn up the sympathetic system, or increase our secretion of catecholamines as a result, and we see an increase in our pulse pressure. Aortic regurgitation is another disease that would cause an increase in our pulse pressure. And this is because in aortic regurgitation, we see an increase in our end diastolic volume as the blood regurgitates back from the aorta into the left ventricle. So the left ventricle has even more blood to pump during systole, which increases the systolic pressure in the aorta without causing a huge change in our diastolic pressure, resulting in an increase in our pulse pressure. Hope you're following me there. And finally, the last thing that will increase our pulse pressure is age. An increase in age results in an increase in pulse pressure. So in older patients, we see increased systolic blood pressures. Do you remember why that happens? So once patients hit about 55 years of age, the systolic blood pressure tends to increase relative to their diastolic blood pressure. Diastolic blood pressure when they age typically stays about the same or even decreases. This has to do with arterial compliance. If we remember back to our physics, is that arterial compliance, or C, is equal to the change in volume over the change in pressure. So as we age, the elastic fibers in our aorta, which are very much important for maintaining compliance of our arteries, start to become old and they start to lose their elasticity. So we actually see a decrease in elasticity, and as a result, our blood vessels, our big blood vessels such as our aorta, cannot stretch like normal, which causes a decrease in compliance. So our compliance goes down, the volume stays about the same, the volume in the blood stays about the same, and therefore, in order to make this work out, the change in pressure must go up, our denominator must increase. And that makes sense. We see an increase in pressure as patients age because of the decreased elasticity and the decreased compliance. These arteries are stiffer, they're hard, they do not expand as well to receive the incoming blood, and therefore you see larger spikes in our systolic blood pressure. That is the concept for why aging results in an increased pulse pressure. The last thing we need to cover in this cardiac output section is how exercise changes our cardiac output. So in exercise, we activate our sympathetic nervous system. And as a result, we increase our cardiac output both by increasing our heart rate and increasing our stroke volume. But as we continue to exercise, it's important to remember that the stroke volume pretty much plateaus. Stroke volume plateaus, and so we have to continue to increase our heart rate to meet the demands, the metabolic demands of our body. So why does this happen? Why does the stroke volume plateau out? Well, we have to remember that we only have a limited amount of blood in our circulation, and we can only venoconstrict, we can only constrict our veins to a certain level, and so therefore we can't increase volume return to our heart because the blood is all in our muscles. There's no way to get it back. So in order to maintain the cardiac output, our heart rate just continues to go up. And so as you continue sustained exercise, you start to see your heart rate continuing to go up and up and up.